about suicide in general, and then information about how we can address it as a faith community. A disclaimer I always like to give is that the information we're going to talk about today is to inform, and it's educational based, not intended to treat, and it doesn't establish a doctor-patient relationship, but I do enjoy building relationship otherwise. And some other things I'll just share about my background that I think is important to just give some context to this conversation is that I am Caribbean born, so I was born in Barbados. I grew up in a very Caribbean Christian household, and that has really shaped who I have become as a person and as a psychiatrist. And my specialty as a psychiatrist is in emergency psychiatric care. So I work in emergency settings and I work in outpatient settings. So when we're thinking about suicide, I am someone who is on really that front line of someone coming into the emergency department, expressing suicidal thoughts, and figuring out what's the best space for this person in terms of next steps. But I want to be able to help you all feel a little bit more comfortable too, of figuring out if someone comes to you before they get to me, what do you do if someone comes to you and mentions that they have thoughts of suicide or thoughts of killing themselves? The other thing I'll point out is that I do run a nonprofit. If you weren't here earlier, I run Christian Mental Health Initiative, where we work with churches around the US, the Caribbean, and West Africa to really increase knowledge about mental health in these spaces. And I care deeply about faith and mental health, so really happy to be able to have this conversation. And I think the other disclaimer I'll mention is that even though I want this to be a safe space, suicide is still a very heavy topic. And I want to just be mindful that for some people, there may be moments that may become uncomfortable as we have this conversation. And if that's you, it's very much okay if you need to take a step out, rejoin us when you feel ready to be able to do that. So I have just a few goals for today. I have a lot of slides, so as I was putting this together, I just kept thinking of more things to add, so I hope we can get through all of it, but we'll get through as much as we can and what is most important for the group. But I really do want to increase awareness about suicide in faith communities. I want to be able to equip faith leaders, so equipping you all with tools to address a mental health crisis, and want to be able to talk about some evidence-based practices and promote compassionate, informed dialogue within faith communities. So again, as I said, it's a heavy topic, but one that honestly impacts many of us. I want to start off really realistically asking a question for really you all in the audience here to raise your hands if you have lost someone you know to suicide. And I'm looking around the room and really just want to take a moment to honor that. That this isn't, for many of us, just an intellectual topic, something that we think about just as an other experience, but it's something that may have impacted our families, our workplace, our schools, our faith communities. So coming from that perspective, really thinking about how do we prevent more suicides from occurring? How do we also honor the lives that have been lost due to suicide? I wonder, and it's an interesting question, but one that I really did want to put out to the group because it's going to relate to what we talk about going on. But in hindsight, I wonder if anyone feels willing to share if there were warning signs they noticed about the person that they knew who experienced or who died by suicide, kind of the hindsight 2020 thoughts that may have come up. And I'll ask the moderators if anyone feels comfortable to share that we take a microphone to them. But I can start that conversation as others think about it. I had a friend in medical school who died, unfortunately, by suicide. And in hindsight, even as someone who was going through the training, something that I recognized was there was a time period a couple of weeks before he passed that he called me several times back to back, which was out of the norm for him. We were close, but not close to the level, honestly, that he would call me, and then also that he would call me back to back. I carry a lot of guilt, truthfully, about not answering the phone call. It happened around, or actually literally the day of my sister's rehearsal dinner for her wedding. He called me again on her wedding, and I just actually didn't have my phone. And truthfully, then it kind of escapes my mind to call him back. And then a couple of weeks later, I had learned that he died by suicide. And for me, I think about that as were these calls a reach out for help and for support? I share that because we're not perfect. Yeah, we're not perfect. The idea of being able to recognize signs and symptoms isn't for us to be able to predict if suicide may happen, but really for us to truly be in community and lend support as much as we can. And the idea of thinking about hindsight helps us to figure out what can we be paying attention to going forward so that these losses are reduced in the future. Did anyone want to share? Thank you.
I can yell also. I don't know if you. It was a younger cousin, and he was in middle school, and he had been experiencing bullying. And you give this support, but not realizing how. I was already in college, when this had happened, but not realizing how really intense that. We know that bullying is bad, but really not realizing how much that really impacted him when he talked about it and that experience.
Thank you for sharing, and I'm sorry for your loss.
Two veterans that I knew quite well, both young men, and there was no sign, nothing to indicate. He came to work both occasions and found out that they had committed suicide the night before.
Thank you for sharing, because that's actually another really important point. Although there are many warning signs for us to pay attention to, sometimes suicide also can be impulsive and kind of seem to come out of nowhere. And though there may not be signs that are visible to us, there actually may be thoughts going on in the person's mind that may not potentially have been shared with others.
When I was 19, I lost my brother to suicide. My brother was 21. He had been struggling with addiction for a while, and in the course of his path in addiction had gotten caught up in some criminal charges that were going to be life-changing. And the sign that, to us looking back on, is he was always so neurotic and always so anxious, but in the 3 or 4 days leading up to it, he was perfectly calm. And he had said, it's okay, I've got it figured out, it'll be okay. And looking back on it now, it's like he had already made the plan to end his life, and we just didn't know, and that's what brought him peace, not that he was going to wait and see what the outcome of prosecution and his path would be after that.
Thank you for sharing. I'm sorry about your loss. And we'll actually talk about that too, that sometimes that calm can be an indicator that someone has maybe come to terms with a decision, and that might be the signal for us to reach out and help even more. Another question I want to ask to the group, and maybe we can just kind of shout this out, but how equipped do you feel to identify the warning signs of suicide in someone in your community or congregation? You can kind of shout out whether it's not at all equipped, or just say the number, maybe 1, 2, 3, or 4. How are you feeling in terms of how ready and equipped you are to address and to recognize signs of suicide?
4.
3, 2, 4. Okay. So I'm hearing some 4s. I heard anywhere from a 3 or 2 to a 4. Any 1s? No shame. It's a safe space. Any 5s? Any experts out here? You have a 5? Yes, sir. Yeah, it is. As I shared, it's a really tough topic. So as I said, if at any point you feel overwhelmed, I welcome you to take a step out and then to return if you feel comfortable or not. I won't mind. I would completely understand. So I heard that there's anywhere from feeling minimally equipped to feeling very equipped to identify warning signs of suicide. For our person who feels very equipped, I'm curious, what makes you feel very equipped to identify warning signs?
Testing. Okay. Reason why I say that, I mean, I've been working in the behavioral health field for close to 40 years. Also, I mean, I've done everything from inpatient to psych crisis, mobile team. Also, in my former church, I was chairman of the deacon board for over 15 years. So I always had a conversation with the congregation, with my background. So, you know, I can spot it a mile away. My wife's a nurse. We met on the psych unit, so it's in the family. So that's basically the reason why I say I'm very equipped. Not perfect, but I can sense it, I can notice it, and either I can direct them or I can point them in the right direction.
Thank you for sharing. And I think I really wanted to hear that perspective because it takes time. What you shared is decades of experience, and that's on the professional side and in community, at your church, working with people, and you also were paying attention because you're looking to, and you said you could spot it a mile away, you're paying attention to the people that you're in community with. How about maybe someone who said a 2 or a 3? Why are you feeling maybe not so equipped? Yes.
Well, I feel like sometimes I can see it, sometimes I can smile. But for the vast majority of times I can't. And my second child had a suicide attempt. And I didn't see it coming. I knew they were experiencing depression. Depression runs in the family. But I didn't see the suicide attempt coming whatsoever. So that's why I say I'm minimally to neutral.
Thank you for sharing. And you bring up an important point as well, that we often focus on a completed suicide, but for every completed suicide, there are more than 100 attempted suicides. And that's just as important for us to talk about as well. So we'll kind of keep going, and I actually have a question for you all because I missed the first session. Did they go over like statistics about suicide rates and things like that? Okay, great, because I didn't want to duplicate it if you already saw it, so I was going to share some statistics. But to start off, I'm going to bring this slide up a few times. It's a mnemonic or abbreviation that I use that can be helpful to remember what to look for in terms of suicide warning signs. So as a med student, we always would make up like things to remember, things by the mnemonic. So be vigilant, vigilant meaning aware, paying attention. So we want to be vigilant and be paying attention to people that we live with. So we're going to be talking about behavioral warning signs, so things that people do. Emotional warning signs, so the feelings that people may experience. And then verbal warning signs, things that people say that could be indicators of potential risk for suicide. So I'll bring this slide up a few times for us to continue to review it. But let's really just get into talking about suicide. And I want to emphasize it's okay for us to talk about it. It's hard, but it's also okay to do. And I'll say this at some other point too, but talking about suicide actually does not increase the risk of suicide. And in particular, if someone is experiencing suicidal thoughts, you talking to them about it does not increase the chances that they may attempt or complete a suicide. The one caveat I will give to that is we do know that in youth, if there are suicide attempts or even completed suicides in youth populations, sometimes we see something that's called like a contagion effect, where there may be peers maybe copying the behavior within middle school, high school age. But generally though, talking to someone who is experiencing suicidal thoughts does not increase their chances of completion. So I want to give some definitions because I don't want to assume that we are all on the same page. So suicide, it's death caused by injuring oneself with the intent to die. And these are very important terms and aspects that we need to think about, where it's death, we not being here anymore, and someone is trying to injure themselves with the intent to die. I'm not going to go into the details of other sorts of self-injury because sometimes people hurt themselves without the intent to die, but we're thinking about where the death was caused by an intention to end one's life. And then a suicide attempt is where someone has harmed themselves with the intent to end their life, but they did not die. So again, I want to really differentiate this out because you may have heard of something like cutting, for instance, where someone may cut a portion of their body, maybe the wrist, maybe the thigh, and it's not because they actually want to end their life, but it's a way possibly to cope with pain that they're experiencing, whether that's emotional or physical. But that's different than a suicide attempt, where someone may actually do a similar behavior of cutting with the intent of killing themselves. I also want to talk about some language because commonly we'll say this term commit suicide. And in the field of mental health, we're really working towards shifting that language. Commit, we think of that as really having a shame-based connotation to it, where commit is saying that the person has, done something that's negative, like someone might get committed into a hospital, even that we're trying to get away from using that word, but really just saying that they died by suicide, describing the way in which their life came to an end. Other terms that are important in this conversation would be suicidal thoughts. So someone can have suicidal thoughts and actually not want to end their life. So suicidal thoughts may be intrusive, where thoughts of killing yourself or even having a plan to kill yourself might come up in someone's day-to-day thought pattern in an intrusive way that may be incredibly distressing to them, that goes against what they actually intend or what they desire. And then thoughts of death is even different, where someone may think about dying, and that may come across more like, I wish I wouldn't wake up, or if a bus hit me, I'm okay with that. So it's not that they're thinking about doing anything to end their life, but there are thoughts that come up that basically they think things may be better off if they weren't here. So I wanted to just kind of introduce you to some of that language because there is a nuance to it, just so that you're aware, truthfully. And then jumping into some of the statistics. So the most recent data that I found were from 2023, where over 49,000 people died in the US by suicide. And what that means is that there's about one death every 11 minutes. And thinking even more specifically, that means that during this discussion, maybe about 6 people or so around the US will die by suicide. So it's something that is happening and happening regularly, and the goals of conversations like these are to bring those numbers down. And honestly, it would be really great to see that go down to 0, where people are not dying by suicide. But like I mentioned before, the number of people who have died by suicide doesn't tell the whole picture. We think about the fact that in 2023, based on our rough estimates, and truthfully this number may be even larger, almost 13 million people seriously thought about suicide. About 4 million made a plan, and 1.5 million attempted. So we really want to think about the fact that this is incredibly wide-reaching across the country, and I'll show some numbers as well that show how it impacts communities across races, across ages, across genders, but it does so in different ways. So something that we've seen is that suicide rates are on the increase. Since 2000, the rates have increased by about 37% in the US. There was a dip that started in around 2018 towards 2020, and then we think that related to the pandemic, those numbers kind of shot back up. And the question, honestly, that I think would be a really important one to think about is what led to that decrease from 2018 to 2020, and how can we work towards having that trend start look like that again. It seems as though we may be at the beginning of a downward trend, and we want to be able to continue that trend downward so that not as many people are dying year after year by suicide. So some of the numbers I wanted to show from a race and ethnic group perspective. Unfortunately, there's a pretty distinct, disproportionate breakdown across certain groups, and that's specifically the non-Hispanic American Indian or Alaskan Natives are disproportionately more likely to die by suicide. Same with the Native Hawaiian or other Pacific Islander groups. And then we kind of see the other numbers here that for multiracial, Black, and Hispanic, it's about 9 or so deaths per 100,000 people in the community. Another number to look at, this is actually comparing men to women. We know that men are more likely to die by suicide, and very significantly so. But what's another interesting thought to consider is that women are more likely to attempt. So what that ends up being linked to, I'll skip to this one, is the method of attempt. Men are more likely to attempt through more lethal means, so for instance, with a gun, versus women who are more likely to attempt potentially via cutting, potentially with pill overdoses, and there is a very big distinction of, the women trying more, but men completing suicide much more frequently than women. The other set of data I wanted to point out was the age distribution. So something to be really mindful of is, our golden eagles, that's what we call them at my church, the older folks, that the folks who are 85 or above are the most likely to die by suicide. And as we go forward, we'll think about why that might be, whether it be pain, isolation, feelings of hopelessness, dread. And then we also see it's not a zero number, it's lower, but there are, children as young as 10, even younger, who are dying by suicide. And a data point that I'll talk about in a second, right here, is that the second leading cause of death among those aged 10 to 34 is suicide. So when we think about the fact that suicide is a preventable cause of death, and it is the second highest for this age group, it's even more so of a reason for us to think about how are we really paying attention to these warning signs to be able to intervene on an early end so that people can get the support that they need. So let's talk about some myths. Who's here, well, I kind of talked about this already, but we may have heard that talking about suicide increases the risk. I really just want to emphasize that that is absolutely a myth, that talking about suicide does not increase the risk. And there's plenty of data that have kind of just shown that to be true over and over again. Really what happens is it's the exact opposite, where the more we talk about suicide, the more it decreases the risk. And we really want to aim towards promoting direct mental health communication in our communities. And I'm going to give you an example shortly of what direct mental health communication means. This is a more specific faith-related suicide myth. So a myth that may come up, and let me know if you've heard of this one, that strong faith prevents suicide. Have we heard that? I heard a no and some nodding heads. Okay, so a variation of this may be, they're too Christian, like they would never do that. Or the idea that some people think that if you die by suicide, that means you will automatically go to hell. So they would never do that, right? So those are some of the spiritual myths that kind of promote this idea that, we don't really need to talk about it in the church because, if you come to church, you're reading the Bible, you're singing in the choir, that could never be something that you would even be considering. But the reality is that it just cut out. I can't yell, sorry, so thanks. Hello? Okay. The reality is that faith communities also experience suicide. We've even talked about that here, of how people in this room have experienced the loss of loved ones, friends, and I know one of my mentors, he is very passionate about suicide prevention. He's a leader at his church, he's a retired psychiatrist, and in a 2-year time span, he mentioned that they had 3 people die by suicide in the church. And that really prompted him to make sure that the church was talking about it and having these open and honest conversations. So if you're showing up to your place of worship, you're leaning into your faith heavily, it does help. I do want to make sure that I mentioned that we have a lot of data that shows that if you are a person of faith, it can be protective, but it doesn't mean that it's an absolute, that you would never die by suicide if you're a person of faith. So it's important for us to be proactive in how we're showing up as communities to support people who have mental health challenges. The other thing I'll talk about is stigma. We talked about that this morning with Dr. James, and one of the things about stigma that is unfortunate is that it reduces self-seeking behavior. So when stigma arises, and that's when there is shame or guilt put upon someone for a certain experience, that makes people not feel comfortable to step out and step up and ask questions or seek help. There could be fear of judgment and isolation that keeps people from seeking the care. And unfortunately, the stigma and the isolation associated with that can really perpetuate ongoing decline of mental health. What about stigma specifically in the faith community? So some religious beliefs believe that it can make seeking mental health support seem like it's against the faith. There are some spaces still, fortunately, as I've been going to more and more churches, it's less so, but there's still some spaces where people say, you just need to rely on God, like just let God do his thing. And those sorts of beliefs can make people feel like there's something wrong with them as a believer if they are not seeking, or if they do try to seek support. But one thing that's really important is that there's such a beautiful harmony that actually exists between religious beliefs and mental health, where there's so much guidance that we get in the Bible about using the resources that have been provided. And yes, God supports us. He supports us spiritually, emotionally, mentally, and even physically. And then there's also the provision that we have from providers like a psychiatrist or a therapist that can work together. And then it's a bonus if your provider is also of the same faith as you, so that there can be an open conversation about the relationship between the spiritual and the mental. So one of the things I want to make sure that I emphasize today is that silence reinforces stigma. And for those who were at the session earlier this morning, we talked about that. Like, if the leaders in the house of worship are not talking about mental illness, if they're not talking about suicide, if they're not talking about depression, anxiety, substance use disorders, that makes it seem like that's a space where you can't talk about it. But on the flip side, if your leader is talking about these experiences, whether for themselves, their family, their friends, that lets the congregation know this is a topic we can talk about. And it doesn't have to be talked about in the corner. It can be talked about at these tables. It can be talked about on the pews. It can be talked about at Bible study. And it can be talked about regularly. So the silence is part of what continues on the stigma. How about some risk factors? Because this is something that I think is actually important to know as well. What are things that may make someone more likely to die by suicide, or even to consider suicide? Mental illness, in particular, serious mental illness, so examples like depression, bipolar disorder, schizophrenia, may increase the risk. Doesn't guarantee by any means, I want to emphasize that. These are just things that increase the risk of suicide in a community, or in an individual rather. And then with that, comorbidity, meaning just that the mental illness is existing with a substance use disorder, increases the risk even further. And part of that is actually because sometimes, well, actually a lot of the times, a suicide attempt may occur in the context of intoxication. So for instance, when someone is intoxicated with alcohol, for instance, we're disinhibited, meaning that we're more likely to do things that we may not do otherwise. I mentioned how I work in the emergency department. We see some pretty severe suicide attempts in the emergency department, and oftentimes it's in the context of meth intoxication or PCP intoxication, that maybe someone has jumped in front of a train, and maybe they might not have done that if they were not intoxicated. So knowing about that connection between the two is important, because it helps us understand where do we interject earlier on in the pipeline before it gets to the point of suicidal thoughts. Another thing to be aware of is that past attempts actually increases the risk of future attempts. And that actually is the biggest predictor that we have. So before I mentioned that in 2023, there were 1.5 million suicide attempts in the US. So those 1.5 attempts are indicators of the people at the highest risk of completing a suicide, because we know that if someone has attempted, their risk of attempting again is elevated compared to the general population. So exposure to suicide also increases vulnerability. So this is what I mentioned before, where we see with the children, that when a child dies, for instance, in a school by suicide, there's a vulnerability in that community for many reasons. It's layered, so I may not get into all the details, but there's the sadness around the loss, and then children also are a little disinhibited, so then there's thoughts of maybe I should do this as well. Maybe some of the thoughts other people might bring up is I want to be with that person who has gone away. So those are that exposure to someone you know is a source of vulnerability for increased risk of suicide. So we always emphasize that in cases where suicide attempts have occurred, intense follow-up is so important because the time closest to the suicide attempt is where the risk is the greatest. Socioeconomics. So we talked about social determinants of health previously, but financial hardships can be linked to suicide as well. We see a lot of persons in our emergency department who experience homelessness, and they come in often with suicidal thoughts. And sometimes people, unfortunately, will kind of poo-poo those thoughts and say, well, if you got housing, then you would feel better. But truthfully, the experience of living unsheltered lives really does impact the mental health of the many folks in Philadelphia, the folks in Camden, who are experiencing homelessness, and that financial hardship does increase the risk of suicide. Social isolation, like I mentioned with our elderly, but also just kind of generally as well, elevates risk. And then trauma and adverse childhood experiences contribute as well to the risks of suicide. So I'm going back to that mnemonic I mentioned before, that we have to be vigilant. We're thinking about the behavioral, the emotional, and the verbal signs, warning signs of suicide. So let's walk through some behavioral warning signs. I mentioned this before, but if there's increased substance use, so not just substance use, but you're noticing that there's an escalation of the use, that could be a warning sign. Dangerous risks. I remember a patient of mine mentioned that, I forget the term he used, but basically that, I think it was like a death drive, I think it was a death drive, that he would just get on his motorcycle, drive up Broad Street as fast as he could, skipping all of the lights, hoping that someone would hit him. That is the type of behavior that could be affiliated with someone who is having thoughts of ending their life. Social withdrawal is another example of that behavior. Things that may be a little bit more subtle and really require you to be in community with that person and asking questions. Changes in sleep, because changes in sleep, and I could have maybe even added appetite on here, because those could be indicators of depression, for instance. Another important one is maybe even giving away important possessions, making financial planning and will planning kind of out of the blue. And that one can be kind of hard because it's important. We should all be working on estate planning and financial planning, but sometimes it kind of comes out of the blue that someone's all of a sudden trying to make sure that all of their affairs are in order, and maybe that's not something that was on their mind previously. Some people are also making a plan or researching ways to die. And these are things, again, that it requires us to be in community. And truthfully, I don't know how likely it is, I haven't experienced this, maybe you have, for someone to come up to you and say, hey, I was researching ways to end my life. To get that information, it requires you to ask and to care enough to ask someone that and be in conversation with them. Self-harming behavior, so the example I gave before, for instance, of cutting, that could be an indicator that someone is having thoughts to harm themselves to the point of dying, but not always, but it's the type of thing that we're paying attention to. So now let's switch over to the emotional warning signs. These ones can be a little bit harder, and again, it requires us to be vigilant, like I said before, that we're paying attention. So sudden mood swings and agitation can be an example. People exhibiting signs of unbearable emotional or physical pain. And I really want to emphasize the two there, that physical pain is a huge reason for many people to seek suicide as an answer, because they feel that there's no way for them to escape the pain that they're in other than by ending their life. Persistent sadness or anxiety could be an emotional warning sign. So that could be like feeling empty, hopeless, trapped, or feeling like there's no reason to live. And then, like someone had mentioned previously, a calmness after severe depression or severe anxiety, that may indicate a resolve that person has to actually act and complete a suicide attempt. And then lastly, with verbal warning signs, we have some examples like someone literally just saying things like, I feel hopeless, I feel guilty, I feel shame, I feel trapped. These are the things that are more common when I'm seeing my patients, that people will say these things. So it's for you to actually be that type of person someone would feel comfortable to share that with, but then also having information about what would you do to respond if someone were to share this information with you. Another one that may not be so obvious is people saying that they feel like a burden. So like especially when we're thinking, for instance, of the elderly or maybe people who need support in the home for their activities of daily living, feeling like a burden often contributes to people feeling the need that suicide may be the best way to relieve the burden for that person who is caring for them. Talking about that unbearable pain, so not just experiencing it, but talking about the pain often could be a verbal warning sign. And then talking about wanting to die. People may not come up to you and say, oh, I have looked up different ways of dying, but they may talk about the fact that they want their life to be over, and that's something we have to really pay attention to. I'll give an example that it sits in my heart pretty heavy, of an example of a child not being heard in her family. In the emergency department, so I see children as well, and someone came in with a suicide attempt, and the family member said something along the lines of, oh, she's just faking it, don't listen to her, she just likes attention, right? And it's important for us not to minimize the feelings and the experiences that, whether it's a child, an adult, young adult, the elderly, whomever, like if someone's coming to you, showing you, letting you know that they are hurting, we have to listen. Because in that child's case, I was very grateful that her attempt did not take her life, but for others it does. And it requires us to really make sure that we are taking these signs seriously when people come to us. So let's review real quick. I want you to kind of shout out, first starting with the behavioral. What are some examples of the behavioral warning signs that may come up if someone is having thoughts of ending their life?
Having a plan,
Having a plan,
Isolation.
isolation,
giving away possessions,
giving away possessions,
increased substance abuse.
increased substance use. Okay, great. So these are the sorts of things that you want to be thinking about, paying attention to, looking out for. And being vigilant also doesn't mean that you're being hyper vigilant. You're not like, overly looking for these things, but you are keeping an eye out, and especially if you recognize changes in the people that you care about. What are some examples of the emotional warning signs that we want to pay attention to? Crying, mood swings, sadness, hopelessness. Okay, great. And then what about verbal? Lashing out.
Repeating that they're gonna kill themselves.
Yep, straight up just people saying that they want to kill themselves.
Expressing that they don't wanna be here.
Expressing they don't want to be here.
Being a burden.
Feel like they're being a burden. Okay, great. So these are examples. This isn't going to be comprehensive. There are potential other warning signs as well, but I want to at least give you some examples of the behavioral, emotional, and verbal warning signs of suicide that we have to be aware of. So I'll pause there. Any thoughts? We went over a lot. Questions? And I'm keeping an eye on the time. So faith-based support for persons experiencing suicide and maybe suicidal thoughts. So one of the things I'll say is faith leaders are key preventers, right? That's a huge part of what this conference is about. That as members in faith communities, you are key preventers of suicide because you're trusted figures in the community. People are often coming to you first with their hurt, with their pain, and it's about figuring out the way in which you can play a role in prevention and support. Having open dialogue in faith spaces is incredibly important. So in this morning session, I actually referenced the event in this picture. If I hadn't have told you, you might have assumed this was just like a church service. But this was at Christ Community Church in West Philadelphia. Dr. James is actually in that picture too. It's me and 4 other psychiatrists, a psychologist, at Christ Community Church with a room of about 150 members of the community, talking about mental health, talking about suicidal ideation, talking about suicide, talking about substance use disorders, and making it a part of the open dialogue in the community. Because what I mentioned before is that keeping silent about these topics in our faith spaces creates more room for stigma to fester. So when we can create open spaces, literally like we are here today, in the church itself, this is creating space for us to talk about it. So I'm giving examples. So if you're a preacher, are you including mental health and suicide discussions into your sermons? When you're praying over people, are you praying for their mental well-being? Are you allowing people to talk about their personal testimonies so that you can normalize struggle and also normalize getting help for the struggle? Are you hosting workshops? Are you hosting seminars to promote awareness? These are the sorts of things that we can do in our faith communities to really create an open dialogue. So this is a part that I want us all to really participate in. I had mentioned before that we need to encourage direct communication about suicide. And this could be really uncomfortable, especially if you've never asked this question before. But I'm gonna ask for all of us in the room to say out loud, are you thinking about killing yourself? What was it like to say that out loud? Harrowing. Other thoughts?
Sad.
What was that?
I just said, I feel sad about it.
You feel sad about it. It's a hard question, and it's not one that, honestly, that we really get taught to ever ask somebody. But it's an important question. We don't want to dance around the idea. If we are concerned about someone in our community, we have to directly address the question. We have to ask, are you thinking about killing yourself? Sometimes we may try to soften it and say, are you feeling like hurting yourself? Do you feel safe? Those are ways that maybe make us feel a little bit more comfortable because it doesn't get to the heart of the matter. But I'm gonna ask us to say it again, because the more times we say it, the more comfortable, not to say that it's easy by any means, but the more comfortable we may become with saying and asking this question in our community. So I'll ask you to say one more time, are you thinking about killing yourself?
Are you thinking about killing yourself?
How did it feel to say that again?
It was easier the second time.
Yeah, easier the second time. And I'll relate, so as a psychiatrist, I'm in the emergency department. I ask this question at least 10 times a day. But when I was a medical student, I was like you all. There was a time I had to ask it for the first time. And it was uncomfortable. It was really weird, even in practice. And then in the emergency setting, I probably mumbled it and was like, are you thinking, are you having any thoughts of suicide? But we have to be clear. We have to say it with empathy, but also be direct. Because there really is only one or two answers that we can accept from this question. It's, are you thinking about killing yourself? Yes or no. If you get something in the middle, that means you need to keep having more conversation with them. We have to understand that it's a yes, and if it's a yes, what do we do next? We'll talk about that. And if it's a no, we still want to continue the conversation. It doesn't end right there. I'm gonna actually have you say this one more time. Third time's a charm. Are you thinking about killing yourself?
Are you thinking about killing yourself?
Because I want all of you, every single one of you who is here today, to feel comfortable that if someone you see in your community is hurting, that you will feel comfortable to ask them that question, because that question can save a life. Okay. So what happens next? I think this might be a better next slide. So if the answer is yes, that someone is having thoughts to kill themselves, you want to bring in support, right? So you are not supposed to act like a professional unless you are a professional. You are to act like a community member who cares. And a community member who cares, a family member who cares, will call 988. 988, the thing that's kind of cool about it, even though it's a national lifeline, the 988 specific to Philadelphia will route you to Philadelphia specific resources. I actually have had to call 988 as a person, like when I was not at work. And it was kind of cool, actually. I mean, it's not cool that I need to call them, but it was cool to see how the system worked. And it's a really cool system in that there's a mobile crisis team that's available. And in the situation where I needed to call 988, they talked to me over the phone, walked me through what resources were available, and they sent a team out to the home to be able to help with an assessment in the home to figure out the next steps. And this was a next step situation where someone needed to be hospitalized against their will, and they helped navigate that process. So 988, especially for the city of Philadelphia, it can be for something to the point where it's suicidal ideation, but even if there are other mental health concerns that you have and you really want to get some support real time, 988 is a really great support number for that. And then in the midst of the time while you're waiting, because I will say as great as a service it was, it did take like 3 hours for them to show up. So in the time of waiting, there's also the important role that you play to still stay with the person. So if they tell you they're having thoughts of suicide, you don't like call 988 and leave. you clear your schedule, truthfully, or at least bring someone else in who can be there with them. To stay and remain as a calm and present support, whether it's with that individual who's having the suicidal thoughts, whether it's maybe with a family who may need some support as well. That's a really important part of the process. Connecting people to care, but staying present, staying calm, staying supportive. And then if needed, I mean, if it's to the point of suicidal ideation, 988 support staff will help you incorporate the professionals, but really being able to make sure that that is something that's a part of the response plan. So I'll go back to this slide where we talk about the professional mental health collaboration. So from a faith community perspective, you want to be able to work alongside mental health providers. So if you are not if you yourself are not a mental health support provider, you can have people in your church who you can reach out to. So for instance, at a few of the churches I've been at, folks do reach out to me from time to time if they have a question, or it's not so acute, but maybe they're like, oh, this such and such is going on in the church, what do you think we should do? Having those sorts of people connected to the church can be really helpful so that you can get connected to the right resources. Developing care plans and sharing them throughout the church can be helpful. So an example, for instance, there's someone I knew who had bipolar disorder, and one thing I really appreciated about him was that he was very open with like what his symptoms looked like and what his signs were of when an episode of mania may be coming on, and he had a care plan already created. So very similar to just like an advanced directive that you may have for your physical health. There are actually advanced directives for your mental health as well, and sometimes it can be helpful for people to be aware of those advanced directives. And then the churches can also work towards having regular training and coordination. And I saw some of you all taking your phones out. Did the QR code work? I hope it worked.
Yes.
Okay, great. So what I created basically, and I mention to people all the time, psychologytoday.com is actually such a really great resource. So what that code should have sent you to was a search that I created where it sends you to Christian psychiatrists or nurse practitioners in the Philadelphia area that you can access and just like figure out if they take your insurance, if they're accepting new patients, all of that. And then another resource on my nonprofit's website, this is just like a PDF, a snapshot of it, but basically the inpatient resources in Philadelphia, the emergency departments, outpatient resources, intensive outpatient resources, and the crisis response centers. So sometimes it's important just to know that information. All right, so I'm getting the signal that I only have 10 minutes left. And I told you at the beginning I had a lot of slides, so we'll kind of see which ones I want to skip to. So I just want to let you know about some formal programs that exist, because I think as you are planning, and I've had conversations with some of you during lunch, that you want to be able to, plan and have programming available at your places of worship. So Talk Save Lives is an organization, or a program rather, that offers training specifically beyond what we could do today to really help you even more so be able to recognize and prevent suicide in your community. And this is a 45 to 90 minute long training, kind of dependent on which version of the course you choose to join. But Talk Saves Lives is something that might be of consideration for you to bring in to your house of worship. Another one that you may be more familiar with is QPR, which is short for Question, Persuade, Refer. This is a 60-minute training. This is, I think, probably the most popular one for suicide prevention. 8 million people around the world have been trained in QPR, and it's basically supposed to be like the equivalent of CPR, but instead for a mental health crisis, specifically the risk of suicide, of how do you ask the question, like, are you having thoughts of killing yourself? How do you persuade people to get help? And then how do you actually refer them to the support that they need? There are many other faith-based programs. This one, Faith, Hope, Life. It doesn't seem to be active in terms of like they're putting out new information, but they still have a lot of information on their website. For instance, they have a video of what pastors can watch if there was a suicide in the congregation, of how you can support the congregation as a whole, and how you as a faith leader can actually make sure that you are caring for yourself as well. So even though it didn't look like when I looked this up, they weren't actively doing anything new, they still have a ton of great information on the website. Soul Shop is another one. This is another training that helps you to be able to prevent suicide in the faith community, and it really does come at it from a faith-based lens. Anthem of Hope, this is another faith-based organization, and they really work towards promoting QPR training. So I wanted to let you all know of different organizations that exist that are faith-based and are really geared towards suicide prevention. I'll also mention my nonprofit Christian Mental Health Initiative. So we really focus on mental health first aid, and though mental health first aid is not only about suicide prevention, it does include suicide prevention, and it's a bit longer. It's a much more extensive training, but we as a nonprofit do offer this, and we had a great opportunity to get grant funding from the Jack and Jill Foundation to provide it, but also for you all in Philadelphia. If you need to get trained or recertified, the City of Philadelphia offers it for free. So that's another way to go about getting mental health first aid training. Here are just really a list of specific Philadelphia resources. One of the things I really wanted to point out is when I talk with folks, I really just want you to know where's the first place to get a foot in the door. So let's say you don't want to call 988 or you don't need to call 988 because the person is willing to get help. You can take them to any emergency department. So any emergency department should have the ability to do a psychiatric assessment and kind of figure out what the next steps are. But in Philadelphia, what's really cool is there are psychiatric emergency departments where they focus only on mental health, and these are called our crisis response centers. And we have several throughout the city. So there are 2 for children, 1 at CHOP, 1 in East Falls, and then most of the academic centers like Temple, Penn, Jefferson, well, no, Jefferson just uses the emergency department, but most of the academic hospital centers also have a crisis response center affiliated, and then Friends also has one in Northeast. These are some of the resources I had mentioned before. They're just links. I think I'll make the slides available so that you can access them. But these resources are all from that Faith, Hope, Life resource that I had mentioned before. Okay, all right, cool. So we have 5 minutes left. I have discussion questions, or I also have, I can just let you all ask questions. But something I wanted to circle back to is, we didn't have a ton of time, but we did spend the past 45 to 50 minutes talking about suicide, talking about recognizing signs and symptoms, and what some of the next steps could be. I wanted to just kind of ask that same question again of, how equipped do you feel to identify the warning signs of suicide in someone in your community or in your congregation? And again, you can just shout out the number. Right here. 4, 5, 4. Okay. So that was my informal poll to see if this was helpful. Basically. So I'm glad that you found this helpful, but as I said, it's not comprehensive. And to be honest, when it comes to anything related to education, you always want to keep learning. You can always learn a new skill. You can always learn a new way to support someone. In fact, even doctors, they make us make sure that we learn forever. So I'm always learning and I'm always discovering something new. And then the question that I have for you is, of the resources that I mentioned, did any stand out as particularly helpful as something you might want to use, or are there other resources that you might want to kind of try to find as it relates to suicide prevention?
I'm sorry, did you say that you were going to make those links and their presentations available?
Yes.
Because I think all of that was relevant.
Got it. Okay, yep, I absolutely can. Yeah, I've already shared with Chandra and Deborah the slides, so yeah, feel free to share. Anything else? Any questions? Yes.
I'm going this evening to speak to men in my church about suffering. And your talk has been encouraging me to, ask a question. I've been thinking about saying, have any of you thought of killing yourself, as opposed to, are you thinking about killing yourself, to open up discussion?
Yeah, I think that could be a really great way to bring it up, and it's a good point. I am by no means telling you to be hello, are you thinking about killing yourself? You have to have a conversation. It should be in the context of you checking in about how people are doing. So what you're bringing up, Ted, is a really great point of saying, you want to set the stage to get a sense of how people are doing, maybe how their mental health has been in the past. So starting with, have you ever had thoughts of killing yourself could be a really great way to open up that conversation. Yes, in the back.
Correct me where I may be. Can you hear me?
I can, yep.
Correct me where I may be wrong, but I'm going to piggyback off of this gentleman's question. Specifically, maybe, just in the black community, in terms of faith and religion. Why is it that there seems to be a core messaging from the pulpit in terms of pain and suffering, and some of the quotation of it is, pray about it, or encourages us, black folk, to pray it through? What's the reality of that when the person actually takes that literally and then still nothing happens? So now you have a person, maybe even me, that's perplexed by it because prayer obviously is the answer, and if it is, it's only coming from a consistency in which possibly it can ebb and flow. But why does the black church, if it does, encourage that method of trying to work through our issues when it may be much more than that?
It's a really great question, and it's a huge part of the work that I do to make sure that we're getting information and knowledge out there. So if a pastor or a leader in a church or any faith group doesn't know about the risks of suicide, doesn't know about depression and the treatments, they can't preach what they don't know, right? Like, you can only talk about what you know. So it requires then spaces like this. Maybe if a pastors are here, I heard there's a deacon here, but if the pastor isn't here, are you taking that information back to the leadership, right? Are you sitting down to have conversations? I have at times in my places of worship, basically, in love, called out leadership and asked for a meeting. Like, I straight up said, hey, I feel like I would like to meet with leadership about how we're responding to X, Y, and Z situation, and let's talk about it. But we can't assume that others are doing that work to become educated, so then we can, with grace, do the job to provide some education to them, so that hopefully from the pulpit message is, let us pray and search for a therapist at the same time. One more question, thank you.
Okay, I just wanted to kind of comment behind that, because I've been in the church all my life, and pastors are likely to call that demonic. If a person is saying they want to commit suicide or want to, they're likely to say that and view it, in those terms. So help can come in various ways, such as like this. But I did want to ask, what is the suicide rate for Philadelphia? I don't know if they already covered that.
I didn't specifically cover it. So the number I found was 12 out of every 100,000 people. The reason I didn't include it is because I couldn't find multiple sources to back that up, but that was the number that I did find, and I only like to put stuff on my slides when I have the source. But I believe it's around 12 out of every 100,000. And if I jump back to the beginning of the presentation, to just give you a source of context. So for instance, this is for the US as a whole, it's 9 out of every 100,000 for Black Americans, the suicide rate. So that would mean, I'd have to actually double check the apples to apples numbers, but that just kind of give you a sense of how that falls on this scale.
Thank you.
But yeah, so I am being told we're out of time. Thank you all so much for engaging in this conversation, and I appreciate you being here.